Long-stem bipolar hemiarthroplasty is sometimes indicated for intertrochanteric femur fractures, especially in certain challenging cases. Here are the common indications for this procedure. First is failed internal fixation. When previous internal fixation such as DHS or intermedullary nail fails due to factors like implant loosening, non-union or poor bone quality. Second is severely comminuted fractures. In cases where the fracture is highly comminuted, which is unstable or irreducible, and fixation options may not be adequately stable. Third is osteoporosis. In elderly patients with significant osteoporosis, achieving reliable fixation can be very difficult. A long stem prosthesis provides additional diaphyseal support in such cases. Fourth is poor bone quality or pathological fractures. Patients with pathological fractures due to bone metastasis, osteomalacia, or other conditions affecting bone quality may benefit from the structural support provided by a long fracture. Arthritic changes or pre-existing hip disease. When significant pre-existing hip arthritis or other degenerative changes are present, a long-stem bipolar hemiarthroplasty can address both the fracture and joint pathology. Sixth is extensive femoral shaft involvement. When there is significant femoral shaft involvement or extension of fracture beyond the intertrochanteric region or a subtrochanteric fracture, a long stem may be needed to bypass the area of concern and provide diaphyseal stability. Seventh is high risk of avascular necrosis. In patients at risk for avascular necrosis of the femoral head, the use of hemiarthroplasty can be considered. Ninth is non-ambulatory or low demand patients. For elderly, non-ambulatory or very low demand patients, long-stem bipolar hemiarthroplasty may be chosen over more extensive surgical approaches like total hip replacement. This procedure offers stability and early mobilization, which is particularly important for elderly patients who might not tolerate prolonged immobilization. The patient, a 75-year-old female, is planned for a cemented long-stem bipolar hemiarthroplasty for an intertrochanteric femur fracture. After a thorough preoperative assessment, general or spinal anesthesia is administered. She is positioned in the lateral decubitus position. The affected limb is carefully prepared and draped in a sterile manner, ensuring that the hip joint and proximal femur are accessible for surgery. A 10 cm surgical curvilinear incision is made, typically using the posterolateral approach, depending on surgeon's preference. In this case, a posterolateral approach is selected. The incision is made along the posterior aspect of the hip, extending distally along the femur to allow for proper exposure of the fracture. The fascia lata is incised to reveal the underlying gluteal muscles. With adequate exposure achieved, we place a Chanley's self-retaining retractor along the anterior and posterior lips of the incision. The sciatic nerve is identified and protected throughout the procedure. Depending on the surgeon's preference, a self-retaining mastoid retractor or right-angled Langenbach retractors can also be used. With adequate exposure achieved, we visualize the intertrochanteric femur fracture, which exits the femur laterally. Once the fracture site is marked, we use an osteotome to open the fracture site, which is very contrary to the more conventional posterolateral approach to the hip used for femoral neck fractures, where we carefully detach the external rotators while flexing and internally rotating the hip to deliver the femoral head out of the acetabular cavity. Here, once we enter the fracture site, the surgeon carefully frees the fracture fragments proximally of any minor soft tissue attachments. We place a deep Langenbach retractor to safely retract the greater trochanter fracture fragments along with the muscle attachments of the abductors of the hip, while also placing a bone hook to distract the fracture distally, longitudinally downwards. Then we progress with placing a pointed Hohmann spike in the anterior aspect of the femoral neck and do a capsulotomy with the periosteum elevator, We strip the capsule off whilst using a corkscrew inside the neck. These spikes are gradually progressed as we use the cautery to release the capsule of the femoral neck circumferentially. Simultaneously, we gradually progress the corkscrew. We also use a nibbler from time to time to remove any excess tissue in the way while changing the position of both the spikes to enter the hip joint space. Gradually, carefully circumferential capsular release helps in easy extraction of the femoral head once in the joint space and capsule is released. We use the corkscrew with simultaneous pull and placement of the Hohmann's bone spike to dislocate the head outwards. This becomes easier if we do a careful circumferential release of the capsule using a cautery and then progressing the head out. A thorough wash is given to the joint cavity. Progressing to the femoral shaft preparation, we place two spikes along the anterior and posterior aspect of the femoral shaft, thus presenting the shaft to the surgeon. Sequential rimming is performed, starting with small reamers and progressing to larger sizes to ensure a good fit for the long stem prosthesis. As we might notice, the femoral reamers are marked with a marker in accordance with the stem length of the final prosthesis, as we are using a long stem. This step helps in preventing of over-rimming and reduces chances of iatrogenic fracture as we rim only up to the mark. Care is taken to rim the canal in line with the femoral shaft to avoid any malalignment and malplacement of the prosthesis. Once the femoral canal is appropriately prepared, a trial stem and bipolar head are inserted. After preparing the femoral shaft, carefully copious amount of intramedullary wash helps in washing the debris, especially when performing a cemented stem arthroplasty. Once the wash is done, a long stem is hammered into the shaft while maintaining the required version and length of the final stem. The trial components are reduced into the acetabulum to assess for leg length, joint stability, and range of motion. This is done to ensure any post-operative lengthening or shortening, which can be very common in IT for bipolar cases. With satisfactory trial results and fit, the definitive implant is selected. The trial is reduced with slight extension of the femoral shaft and traction while simultaneously external rotating the hip. At this point, cementation is prepared. A cement restrictor is then placed in the femoral canal and the canal is thoroughly irrigated and dried. Bone cement is mixed and injected into the femoral canal using a bone gun. The long stem femoral component is carefully inserted into the canal after the cement placement in the canal, ensuring that we have correct alignment and rotational positioning, as in this case we do not have the calcar to act as reference. After the stem is secured with cement in place, the final bipolar head is selected. As you might notice, this is a long stem bipolar which also has multiple holes in the proximal aspect of the prosthesis. We use gauze to prevent any extravasation and spillage of the liquid cement, while also providing longitudinal force to press fit the prosthesis along the cemented diaphyseal shaft. After the stem is secured with cement, the final bipolar head is selected based on the preoperative templating and intraoperative findings. The bipolar head is then attached to the femoral stem. The hip is reduced back into the acetabulum and stability is once again assessed using shuck test. The joint is tested for proper movements and any necessary adjustments are made. The fracture fragments are meticulously reduced under direct vision and temporary fixation is achieved. using encerclage wires. Following the reduction, the fracture is addressed definitively. The encerclage wires are placed around the fracture site to stabilize the fragments around the implant, providing additional support and ensuring that the fracture heals appropriately. In this case, we use double loops of encerclage AO wires for fixation. Wires pass medially along the femoral shaft at the level of the lesser trochanter distally and through the hip abductors proximally. Surgeon uses semicircular wires passing with a handle to help place the wires while causing minimum further dissection of the musculature medially. These encerclage wires are pre-tensed and straightened, making them easier to work with. Using serrated pliers, we tighten the encerclage wires and wind them slowly against each other. We also use wire tensioning devices if we have it available in the OT, and which helps tension and wire the ends of the AO spool. Excess wires are cut using a wire cutter. Then, once the reduction is secure with wires, we can progress to closure. A thorough wash is given after complete placement of the wires. As you can see in this case, the surgeon is passing the wires using a wire passer device. Once in place, you can use your fingers or a plier to place the knot at the appropriate position. In this case, the wire is doubly looped and then an artery is used to place the wire in position, while also pulling the wire with two pliers consecutively. Once the wires are in position, they are wound against each other using a plier. Progressive tightening is done using serrated pliers in a rotational fashion. The fascia, subcutaneous tissue and skin are then sutured in layers and ensure proper wound closure. Early mobilization is encouraged with full weight bearing as early as tolerated. This is the post-operative X-ray. A physical therapy regime is initiated to help restore strength and function, and appropriate thromboprophylaxis is provided. Thank you.